Good afternoon, one and all. This is Trisha from MedWorld Expo, a unified digital healthcare platform that connects manufacturers and distributors worldwide, while also bringing hospitals, clinics, laboratories, and healthcare experts onto one platform. It gives me a great pleasure to welcome you all to today's webinar. It is my privilege to introduce our esteemed speaker for today's session, Dr. Vamshi Krishna Vaddi, who is highly trained and experienced neonatologist with over 10 plus years experience in neonatology extensive care. He holds a MD in pediatrics from Postgraduate Institute of Medical Education and Research, Chandigarh, and Doctorate of Medicine in Neonatology from Ken Hospitals, Mumbai, both among India's most prestigious medical institutions. His prior experience include consultant neonatologist and pediatrician role at Rainbow Children's Hospital, Banjara Hills. Dr. Vamshi has published extensively in peer-reviewed international journals, and his areas of interest includes the care of extremely low birth weight infants, advanced neonatal ventilation strategies, human milk banking, and point-of-care ultrasonography. He is a member of Indian Academy of Pediatrics and National Neonatology Forum, and also has received applause for his research during his postgraduate training. Thank you. Over to you, sir.
Yeah, hi. Thank you for the wonderful introduction. So I'm Dr. Vamshi Krishna. So we'll start my session. Will you allow me to share the screen?
Yes.
Yes. Yeah, is my screen visible? Hello. Yeah, is my screen visible?
No, sir.
No?
Yes, sir. I think it is in loading. Just a minute, sir. Yeah, now we can see introduction to newborn baby, right?
Yeah.
Yeah.
Are
Now
my
it is.
slides Are my slides moving also?
Yes.
Okay. Okay. Wonderful. So good afternoon. Welcome to the session. I'm the neonatologist and the senior pediatrician in the Rainbow Hospitals, Kondapur. So actually, today we'll discuss briefly about what is newborn, how are they special to us, and what are the normal newborn practices and the routine care of the newborn. So we might have seen that so many babies have been born in our family, or we ourselves might have small babies. So those are called as newborn in the first 28 days of life. They're very special. They're very fragile. We need to know what are they and how to manage them. So this gives a brief idea about the practices that we follow for all the newborn babies. So why we need to know about the newborns? Newborns are not the just miniature of the adults, or not just miniature of the routine pediatric age children. So they are the special. They have very unique in their physiology. That is how their body functions, and the health problems are not simple and not similar to the children to the problems that we can see with the children and the adults. Majority of the times we can't understand why they are crying or why they are happy and why they are sleeping. Sometimes we feel that excess of anything can be abnormal, but sometimes these symptoms might be just normal for them. So learning these things is much important so that we can happily take care of them. And the newborn health is the foundation for the life. So in the usually first 20 days is called the neonatal period. So this is the time where the proper breast milk feeding is one of the most important nutrition and the most important health care advantage that we can provide to the newborn is being given in the first 20 days of life. This will not only have the effect for that point of 28 days, but it can have a lifelong effect. We have seen that babies who have been breastfed exclusively have the high chances of being more healthy and less chances of having the respiratory tract infections like cold cough, pneumonias, loose motions, even the number of the babies who have been admitted to the hospitals have been less, and the appropriate amount of the weight gain that happens with the breastfed babies is appropriate rather than with the excessive amount of the weight gain happens with the formula feed. So this neonatal period will affect the lifetime. So certain practices like overfeeding in these babies or giving more amount of formula feed or unhealthy practices can change the body's fat contribution, the development of other organs. So this can lead to more amount of obesity, more amount of diabetes, and the more amount of hypertension in the early onset, maybe around 30 to 40 years. So this period is one of the crucial period for the long-term development. And we can feel that the newborn development, the proper appropriate management of the newborn in order so that we can have a good newborn survival is actually quality marker for the society also. And this newborn care will have definitely on the long-term physical and the neurodevelopmental outcome of the baby. So in this way, the study of the newborn is much more important, and we should have a good knowledge of the newborn so that we can have a long-term good human beings. So before moving further, there are certain definitions that we need to be known in the neonatal period. So usually the first 28 days, traditionally we call as till 1 month, is called as the neonatal period. We can divide this neonatal period into early neonatal period, that is in the first 7 days, and the late neonatal period from 7 to 28 days. So this has been defined because some problems that happen in the early neonatal periods are different. Some problems that happen in the late neonatal period are different. So based upon this, we neonatologists and the pediatricians will treat and do the diagnostic test. So there's also called as a perinatal period. So when the baby is in the mother womb, we usually calculate the weeks in the gestation. Normally they get delivered around 37 to 40 weeks of the gestation. So the perinatal period is a period where the baby is from 22 weeks of the gestation in the mother womb to the first 7 days after the baby has been born. So this 22 weeks to the first 7 days of the day of life is called as perinatal period. So what is called as live birth? So when the baby, so any product of the conception, irrespective of the weight of the baby can be 500, the weight of the baby can 3 kilos, or irrespective of the gestation, the baby can born at 24 weeks or the baby can born at 40 weeks. When this product of the conception is separated from the mother, show the evidence of the life in the form of heart rate, in the form of breathing, in the form of certain movements, then it is called as a live birth. So we call it as a stillbirth. Stillbirth is the fetal death that has happened from 28 weeks of the gestation, that is of 28 weeks in the mother womb, or when the weight of the baby, sometimes the gestation may not be known in the Indian population, where the majority of the mothers may not be that educated, so that they may not have done the assessment of the gestation appropriate from the time of the last menstrual period. So we take approximately the weight of the baby, like 1,000 grams weight, till the if the death happened from that 28 weeks or the 1,000 grams in the womb, or that happened during the birth process when the baby has been delivered, if the baby doesn't show any signs of the life, like no heart rate, no breathing, and no voluntary movement, then we call it as stillbirth. So we need to have certain more definitions. So nowadays, because of late marriages, because we are very ambitious, we want our educations and our occupation to be at a higher level. So we are postponing our marriages and we are delaying our babies. So this lead to so many mothers becoming pregnant, either because of spontaneous, more because of IVF in the around 35s and around 40s. So these mothers have other problems like hypertension, diabetes, or themselves as very less good environment for the baby to be grown in the womb. So these babies might get delivered early. So these delivering early, that is the pre-delivery of the babies before the 37 weeks of the gestation, is called as the preterm deliveries. If they reach 37 weeks and on, that is called as a term gestation. If they are delivered before this 37 weeks, they are called as a preterm delivery. In the preterm delivery also, we have different classifications. If they are getting delivered from 34 weeks to just before 37 weeks, they're called as a late preterms and near preterms. So these called as late preterms and near preterms, they usually just looks like a maybe around 2.1, 2.2 kilo babies. They may just look like a normal term born babies, but they're preterms. They might have not get that maturation skills adequate similar to the term babies. And there's called a moderate preterm. So as we progress much before, the severity of the diseases and the severity of the illness will be severe. So we have a moderate preterms where the babies are being born 32 to 36, 6/7. And we have a very preterm babies where the babies are born from 28 to 31, 6/7, and less than 28 weeks called as extreme preterms. Nowadays, we are able to salvage the babies from 24 weeks onwards. So there are certain centers in worldwide where they are even salvaging 22 weeks onwards also. At least in Hyderabad, in our centers, we are able to salvage the babies from 24 weeks onwards. So this why do you need this classification? We can call all the babies are born less than 37 as a preterm. Why should we label them in the different names? We need to label them different names because their outcomes, the duration of the hospital stay, the medical complications, and the kind of the care that we provide to them, the kind of equipment that we use for them will depend upon this classification. If the babies were born on less than 28 weeks, we need to deliver in a very higher centers where they have all the equipment to provide the warmth, incubators, ventilators, human milk bank for providing the milk, total parental nutrition, a cardiologist, an ophthalmologist, a neurosonogram specialist, that's a radiologist who is specially trained in the brain scans of the baby, and a specialized nurses need to be there to carry these less than 28 weeks. They can't get managed in a small setups. From 28 to 31 weeks from the nurse, they can be managed in a small, a bit more than the normal ICUs, but may not be that level of the ICUs that need to manage less than 28 weeks. And this moderate, that is 32, 36 by 7, and the late preterm, this can be managed in a small NSUs where we have a good round the clock management of the pediatricians and the specialized nurses. Also, we classify babies based upon the birth weight. So whenever the baby is born, we ideally check the weight of all the babies. So if the baby's normal weight of the baby is 2.5 to 3.5. Any baby who was born less than 2,500 grams called as low birth weight. If that low birth weight is less than 500 grams, we call them as special as very low birth weight. And if the birth weight is less than 1,000 grams, we can call as extremely low birth weight. So the smallest the baby that we have salvaged is 375 grams baby. So it's almost just like a small, maybe or much slightly bigger than our hand. So with the advance of the technology, with the dedication, with the kind of the training, we are able to save the very, very small babies. And similar to the gestation, the birth weight also will show to us how severe the baby will be there, how all the management skills and the profit and the kind of the people that we want to manage these babies. As the baby's weight is low, we need much more train and much more higher equipment. And there are certain data which is a quality indicator to show that how well our system is able to salvage these babies. So NMR called as neonatal mortality rate. So this is the death of the infant that has happened in the first 28 days. That is the neonatal period, and divided by the 1,000 live births. This is called the neonatal mortality rate. And we call it the perinatal mortality rate, where the number of the deaths that happen in the stillbirth, that we have seen that more than 28 weeks and 1,000 gram babies, plus the deaths happen in the first 7 days divided by the 1,000 live births. So the NMR neonatal mortality rate is around 19 per 1,000 live births. The target is to have a single digit as soon as possible. So if the neonatal mortality rate is decreasing, then it shows that our delivery practices and the kind of the quality that provide for the mother and the baby is much advanced. So now once you understand what is neonate, why they are different from this thing, what is the importance of knowing the basics of the neonatology. Now we'll move on to how we deal with the babies. So once the care of the newborn starts before the baby born, that is in the antenatal period. So the antenatal period, usually your obstetrician and the gynecologist are the best person to take care. If there is any complication, we usually have a combined counseling sessions with the parents, and we have a team of doctors where we discuss about the problems, we'll plan and discuss with the parents. If it is suitable, this thing, we carry on this thing. Or if they're not satisfied, we can still discuss about the other options, and finally we make a plan. So the antenatal program, antenatal management of the babies, I'm not going because I'm a neonatologist, will deal with the babies from the babies will born delivered. So the first and the foremost, whenever the baby is getting delivered, there should be a proper trained pediatrician or a neonatologist to assist in the initiation of the breath for the baby. So this is called as neonatal resuscitation. So every delivery should be attended by one trained person who can able to manage the neonatal resuscitation. If any high risks like any preterm deliveries, or if any number of the babies are more like a twin deliveries, then we need both personnel who have been trained in the neonatal resuscitation. So my job starts when the baby is born delivered. So that is called as neonatal resuscitation program. So what is meant by birth asphyxia? Sometimes we often hear that my baby has not cried at birth, their baby has not cried at birth. They're called as, the doctors use a term called as birth asphyxia. What is meant by birth asphyxia? The birth asphyxia means that when the baby has been born, ideally the baby starts crying. So the crying, it doesn't mean that baby is active. The crying means that when the baby cry loud, that means that baby started breathing. So when the baby is in the mother's womb, usually the blood circulation from the mother to the baby through this umbilical cord will transport the oxygen, glucose, and all the nutrients for the baby. Once the baby has been delivered, we separate the umbilical cord from the mother, then the baby has to breathe. That means by cry in order to initiate the breathing. Then only the oxygen levels will go into the lung. From there, it is circulated to the entire part of the body. So if any baby is not able to establish appropriate breathing at birth, that is called as a birth asphyxia. Why is birth asphyxia that important? See, if the baby doesn't initiate birth after the being separated from the umbilical cord, the baby brain and the body will not be getting appropriate amount of oxygen. That can lead to a trauma which can be lifelong lasting, and sometimes we may not have we can't do anything after this severe kind of asphyxia happens. So we should avoid the birth asphyxia. Till now also 19% of the neonatal deaths are attributed to birth asphyxia. It's one of the leading cause of the neonatal deaths in the world. So birth asphyxia not only damages the brain, it can damage every part of the body requires oxygen. So whenever the oxygen is not delivered to the lungs, it can lead to the lung damage. If it is not getting delivered to the kidneys can get damaged. If it's not delivered to the intestines get damaged. But out of the things, the one of the more important that can have a lifelong problem is brain. The appropriate oxygen is not reaching to the brain, then that can lead to a damage in the brain, which can lead to the lifelong brain-related morbidities in the baby. So we usually, majority of the times, around 85% of the times when the babies are born at the near the term gestation, that's on more than 37, they initiate the breath within that 10 to 30 seconds, and there is nothing we need to do. Only 10% of the babies, of the 100 babies, need some kind of support from our side in form of just drying the baby and stimulating the baby. So again, the stimulation doesn't mean, as we see in the movies, turning the baby up and down and hitting the baby. We just rub the back of the baby for maybe 1 or 2 times, or flip the sole of the baby 1 or 2 times. Beyond that, if you delay, that can lead to more damage to the brain. And only 5% of the 100% of the babies will require some amount of oxygen support for the babies in order to have a successful transition. And 2% of the babies require mechanical ventilation, where we put the endotracheal tube into the lungs of the baby and provide the respiratory support. So, and very, very less than 1% receive the cardiac compressions, and less than 0.1% babies receive the special drug called as adrenaline in order to stimulate the heart. So as soon as the baby is being born, we usually assess the baby for the resuscitation, and 85% of the babies they just initiate the breathing without any other support. Only 10% of the babies will require some support. Very few babies will require oxygen, positive pressure ventilation, and putting the tube in the lungs for providing the support. And very, very few babies will require additional support to initiate the heartbeat to start, like a chest compression and drugs like the adrenaline. So we call it as normally in adults we call it as ABC of resuscitation, airway, breathing, circulation. But in newborn, the temperature is a paramount important. Without bringing the temperature to normal levels, if you do all the ABC, the baby we can't salvage the baby. So the temperature is a paramount important, and is the first important thing that we need to stabilize as soon as baby is born. So T is for temperature, A is for airway. That is, we need to position the baby and clear the secretions if there is anything. Breathing, we can try to stimulate the baby by rubbing the back or flickering the sole, and we can provide some amount of oxygen. Circulation, as we discussed, if the baby is not crying, we may compress the chest. And drugs, like we use the specialist kind of drugs like adrenaline, or sometimes we give the normal saline boluses, and in order to initiate the heart rate of the baby. So this is an algorithm that we usually follow, and all over the world, the NSUs have this kind of algorithm. This is called a neonatal resuscitation program algorithm. So we follow this algorithm meticulously. So whenever we go into the labor room, we first ask the 4 important basic questions for the gynecologist. So what is the gestation that we are expecting? How many babies we are expecting? Is the meconium, is the liquor is clear or not? So the amniotic fluid, that is called liquor, if it should be usually clear. If it is stained with the meconium, that is the first stool of the baby. If it gets mixed with the amniotic fluid, that can lead to inhalation of that meconium into the lungs and can lead to the damage to the lungs. And 4, is there any what is the umbilical cord management? So once we know these conditions, and once the baby is being born, we again think of 3 important questions in our brain. So is the baby term gestation, that is the baby born at 37 weeks or not? The next important thing is, we also ask whether the tone of the baby is not. Normally, we have seen that when the baby is being delivered, they usually flex all the upper limbs and the lower limbs. This is normal. It's good for the baby to have in this position so that they can accommodate in the mother room. It's not that the babies are very tired, we need to stretch them and pull them and damage them. So having a good tone means the baby brain is good, and that the baby is flexed a good more in the uterus, and after the delivery should be in the same way. and whether the baby is breathing or crying. If all the three is born at term gestation, the tone is good, that means the brain is good, and the baby is breathing or crying, then we give the routine care. What is the routine care that I explained in the subsequent slides? Suppose these are all the equipment that we have in the labor room. We have a warmer in order to provide the heat for the baby. We have a blankets and towels which are warm enough to cover the baby and clean the baby. We have a temperature sensors, and we have a specialized thermal matrices and plastic bags for small babies in order to prevent the heat loss. We have a syringes to clear their way. There is a suction catheters. We have stethoscopes. If the baby is required for positive pressure ventilation, I mean providing the oxygen or the breath, we have a specialized equipment called as bag and mask, bag and tube, and we also have a TP resuscitator. If the baby require tubings, we have all the equipment and the drugs like adrenaline. So these are all the equipment checklists that we have. And every day when we go to the labor room, we check all this whether they're in appropriate place and they're working or not. Then only we start the deliveries for the baby. And every time we use them, we always try to replace them immediately so that for the next baby, these all things should be in place. Because even if one is not available, at any point of this algorithm, we can have a problem and we cannot proceed further. So briefly, so first we'll do this antenatal counseling. We'll discuss what are the chances for the baby to cry, what are the condition of the baby. We have a team, we'll do the team briefing, we will divide the work among our respective doctors and sisters. We check the equipment, and once the baby is born, we have these questions: term gestation, tone, or crying. If they are good, then the baby will stay with the mother and will continue the evaluation and do the rest of things. Suppose if the baby is not born, then we first do the initial steps. All these things should be done in a minute time. So this is called as golden minute. In a 1 minute time, immediately after the baby is born, within the first minute, we need to establish the respiration for the baby. If you delay beyond this 1 minute, that the brain can lead to damage. So this 1 minute is much more important. That's why we should not stimulate the baby too much and damage the brain. So if the baby is not cried, immediately we'll receive the baby under radiant warmer. Radiant warmer is a machine that provides the heat for the baby. And we dry the baby and just stimulate the baby by rubbing or flickering the thing. And we clear the secretions if necessary. If the baby is still not breathing or the heart rate is not good, then we provide the baby with the breathing supporting agents. So the breathing supporting agents is called positive pressure ventilation. Positive, we are providing some positively, we are providing the pressure for doing the ventilation for the baby, and we'll reassess. If the baby is still not able to develop good respiratory efforts, we can put the tube in the lungs and provide the breath. And if the heart rate is still low, then we provide the baby's chest compressions. And if still not improved, then we provide the baby specialized drugs called as adrenaline. I'm not going too depth into this algorithm because it itself is a 2 days course that we usually go for a neonatal resuscitation program. So I'm just giving a brief idea how do we manage the babies and all things. So we can see this target oxygen saturation table. So during the corona, we have got off so many awareness that the normal oxygen saturation in the adults is usually beyond 90 to 94%. But in the babies who have been just born, the saturation takes at least 10 minutes to reach the 90% of the value. So immediately at the birth, if you have a very low saturation of 60 to 65%, when the baby starts crying, taking breath, slowly the oxygen levels build up in the body and your oxygen saturation will move from the 60% to 90%. It takes almost 10 minutes for the baby to reach 90%. So don't worry, whenever the baby is born, the saturation will be low. So when we're providing this positive pressure ventilation, that is we're providing some pressure support for the baby to initiate the breath. We usually do three kind of things. You might have seen, if you are a doctor, you might have seen this self-inflating bag in your labor rooms. And this is a floor anesthetic bag that we can see in the OT theater, where we provide this positive pressure ventilation to the adults. And this is specialized equipment called as TP's resuscitator. Nowadays, all the high-end NSUs are using this TB resuscitator in order to provide the ventilation because it's very good equipment where it can provide an appropriate pressures, and it also provide a specialized pressure called as positive and expiratory pressure. So the lungs will not get collapsed if you use this. So nowadays this became a norm to use this kind of equipment in all the labor rooms where we deliver high risk cases. So there are levels of the newborn care. So we have 4 levels of newborn care where we classify the newborn based upon the newborn NSUs based upon these things. One second. Sorry. So level 1 where we so the level 1 NSUs where we just keep a normal term babies or a late preterms who are initially stable, just need some support from them, some some support from us for the mothers to manage these babies. The level 2 where we keep a much more smaller babies are 32 weeks or more or 1500 grams or more, where they may require small kind of ventilation, small from the post pressure ventilation for a prolonged period like CPAP, or we can use this as step down care from the level 1. In the level 3, where we keep much smaller babies, less than 32 weeks and less than 1.5 kgs, where we can even provide the ventilator support. And the level 4 is the high level of NICUs, where we provide cardiac surgeries, pediatric surgeries, and even we provide the extracorporeal membrane oxygenation, that is an artificial ventilation and the circulation. So at least if any babies who are preterm, they should be get delivered in a level 2 to level 3, because if these facilities are not available and there is no appropriate trained personnel, it is very difficult to salvage these babies. And the National Health Missions has given some names for like a newborn care corner. That is the norm. Every newborn delivery unit have this newborn care corner where we'll receive the babies, and we can just see the babies and refer the baby sick and sick and risk babies to the higher facilities. The newborn stabilizing units called as NBSU, where this should also present in all the birthing units, where they can provide the sick care to the neonates, may be low, but not that low, maybe around 1.8 kgs and more. And they can they can be the first referral unit for the small centers. And they're called as SNCU, special newborn care. Nowadays in our Telangana, we have so many special newborn care units that are present in all the districts. So where they even can manage small babies less than 1800 grams also. And they can do some ventilation for these babies until unless they require very high-end and high-end ventilation and high-end care. So nowadays, new concept is being delivered called as mother and mother NSU. So mother and NSU is a novel concept. Traditionally, what we'll do is whenever the baby get delivered in the labor room, if the baby is sick, maybe because of preterm, maybe because baby has not credit bad, maybe baby has having respiratory difficulty, or maybe has some other congenital anomalies, we shift the baby from that labor room to the NSUs. So we are separating the mother and the baby. Nowadays, the new novel concept has developed is called as mother NSU. So where rather than separating the mother and baby, we have a big NSU where we have a delivery bed for the mother, and beside that delivery bed we have a newborn either incubator or a radiant warmer, where both the baby and the mother can be kept together immediately after the delivery. So the mother bedside will be the radiant warmer or the incubator, and the mother, as soon as mother becomes stable, she can provide the care for the baby so that she will be involved much earlier, and this kind of bond will lead to better development of the brain and the better outcomes in the baby. And we have seen that a number of studies are being going on in order to see this mother and child NSU is much more beneficial for the baby, because by keeping the mother just beside the baby, they can initiate the kangaroo mother care, so that kangaroo mother care is where the mother can keep the baby on her chest directly with the skin to skin contact. That can lead to better weight gain and better milk output and better brain development in the baby. So now the studies are going on. Specialized mother and NSO is being developed in a few centers where they want to study this and want to show to the world that this mother and NSU is much better than the routine NSU. But it's a very cumbersome process, and it needs a very big and large NSU with so much of healthcare personnel dedicated to them. Maybe in the future we can plan in this way. So now we'll discuss how to care. So now we have a normal baby. And if the baby is requiring resuscitation or anything, we shift the baby to NSU. The NSU care is much advanced, and we're not discussing this in this session. So when the baby is stable, baby has cried, is a good term baby, baby is breathing and everything got settled, we hand over the baby to the mother. So from here, the care of the normal newborn baby starts. So anytime at the time of the delivery, we need to prevent the sepsis for the baby. If the babies get infection, it will lead to so much of sickness levels in the baby, and sometimes it can lead to the mortality in the baby also. So prevention of the infection is the paramount important. So there are 5 cleans to prevent sepsis at birth itself. We should have a clean hand, so you should wash your hands and wear a sterile glove. We should not never attend the birth without hand washing and without wearing a sterile hands. The surface should be clean. It should not be stained with the blade or should not be stained with the amniotic fluid. We should cut the umbilical cord with a clean, sterile blade. We can't cut with the normal scissors. We should have a sterile blade. Also, we can. Some people will say that so the blade that we usually use for any kind of a cutting or a shaving purpose, they're not sterile. So the sterile blade is a surgical blade, and they label it as a sterile. So that sterile blade only should be used. Clean tie. Previously, we used to tie with some cotton cloth or something like a thread, but they are not sterile. Nowadays, we are getting a sterile umbilical cord clamps. We are using only those things. And then we need to keep the cord clean. We should not apply anything on the cord. So not even turmeric, not even cow dung, nothing, not even any antibiotic cream or pot also not required. As long as you keep it clean, dry, the cord will heal by itself. So these 5 cleans are very important in order to prevent the infection in the baby. The second most thing is prevention and the management of hypothermia. Temperature is the one of the most important vital in the newborn. So when the baby is in the mother room, the temperature of the mother will be around 36 to 37.5 degrees centigrade. As soon as the baby gets delivered, the AC will be present in the delivery room. So that temperature should not go below 25 degrees centigrade. If the temperature go below 25 degrees centigrade, then the newborn will become hypothermic. That can lead to more amount of damage in the baby. We should always cover the baby with a pre-warm linen. So we should keep the linen under the radiant warmer heater source and get it warmed, and then only we should use to cover it so that the baby temperature need to be maintained. And immediately after delivery, if the baby is good, we keep the baby on skin to skin contact over the mother's abdomen. So from the mother, the baby will receive the temperature. So one, the surrounding temperature is optimum. Two, you are covering the baby. Three, you are providing the skin to skin contact with the mother. So in this way, we can maintain the temperature. So when you're providing the skin to skin contact, we should at least provide for 1 hour. It's not that we're putting the baby on the mother and removing. So by providing this skin to skin at least for 1 hour, the temperature of the baby will be good, and the baby will, there are high chances for the initiation of the breastfeeding. The chances for the getting the low sugars in the baby will be low. So usually previously as soon as the baby was being born delivered, the umbilical cord which connects the baby and the mother used to be cut and immediately dead. But the studies have shown that if you delay that clamping by around 30 to 60 seconds, there will be certain amount of the blood that will be transferred from the placenta, that is from the mother end of the placenta. That's usually the connection between the mother and the baby. So that blood from the placenta will be transferred to the baby. So that will lead to almost some extra amount of the blood in the baby, extra amount of the iron that will improve the hemoglobin status of the baby, iron levels of the baby, and it decreases the chances of the anemia, that is low hemoglobin, around 2 to 6 months. With this, the chances of the babies having a better brain development is high. And cleaning of the baby, we often seen that the newly joined sisters or doctors usually wipe out the baby completely. So we need to just wipe the blood and the meconium. Meconium is the first part motion. So there will be some kind of a wax kind of thing that is covered over the baby, which is called as vernix. There is no need for it to clean completely that vernix. That vernix is very good for the baby. It provides the smoothing of the skins. It maintains the temperature. We need to clear only the blood and meconium. We often see that parents also asking, doctor, this baby, my baby has not been cleaned good. When you go and examine the baby, there will be this vernix will be there over the body. And we explain them, no, this is good for the baby. It will improve the baby's skin condition. It will act like the moisturizer and it will prevent the heat loss. Then only they will understand. Otherwise, they often blame the sisters that they have not cleaned the baby. So vernix need not to be clean. We just need to clean the blood and the meconium. There's a motion. If baby has passed, it should be cleaned. So as soon as the baby get delivered, once we are done the delayed cord clamping, we separate the baby. We usually check the weight of the baby and we'll give the vitamin K. So the vitamin K it should be given for all the babies at birth. If it is more than 1 kilo baby, we will give 1 milligrams. If it is less than 1 kilo baby, we need to give 0.5 milligrams. This is mandatory for all the babies, irrespective of the weight, gestation, water things. If you have a live born baby, they should get vitamin K. Then we need to examine the baby from the top to bottom, and then we'll communicate the baby. Examination, what are things that we'll need to see, I'll explain next slides. Then we'll communicate with the family that, okay, you have a baby born at this point of time, is a male or a female baby. The baby's birth weight is this, and the baby is good, or the baby is having fast breathing, or the baby is a preterm baby. And if it required, if any complication is there, we'll shift the baby to the NICU, or if the baby is everything is good, then we'll advise them to initiate the breastfeeding, and we'll tell them that we'll monitor the baby for subsequent development of any complications. And we will always try to keep the baby beside the mother. That's we call as rooming in. That is very important for the baby brain development and successful of the breastfeeding. So we'll have a clear, thorough examination of the baby from the top to the bottom to look for any life-threatening anomalies and birth injuries. We may not identify all the small anomalies, but major anomalies should not be missed. So normally we'll check the back to look for any neural tube defect. The spine is normal or not. We check for the Down syndrome faces like a Mongolian slot. We check for the cleft lip or palate. We'll check for any club foot where the foot of the baby will be turned inwards and have a equinus. We'll check for the hip displacements or weakness of the hip. We'll check for any eyes that have a cataract. The cataract is where the lens get wide. And we'll check that hearing for the baby once the baby getting discharged. And we auscultate the chest of the baby to look for any murmurs to rule out the congenital heart disease. So these are the major life-threatening anomalies that should be sorted out. So these are all the things that again we are shown here in the picture. We'll check the head of the baby, we'll check the frontal, that's the opening that is present, we'll check for any dysmorphic faces, we'll check the eyes for any cataract. We usually before discharge we'll put a red reflex, we'll see the red reflex. If the red reflex is abnormal, then based upon the how the reflex is abnormal, we can identify the eye abnormalities. We'll check the mouth, we'll check the upper limbs, we'll check the abdomen, we'll measure the liver and spleen. We'll see the chest movements. If the babies are in breathing difficulty, fast breathings, chest in drawings, we'll auscultate for looking any murmurs. We'll examine the hip for the weakness of the hip. We'll check the lower limbs for any abnormalities, and we check the femoral pulses in order to rule out major blood vessel obstructions. So this is an RBSK program, Rashtriya Bal Swasthya Karyakramam, where these are all the congenital anomalies. If there are anything is present, we need to report them immediately. And also we sometimes, especially in rural areas where the mother might not be sure about her dates and might not have gotten a dating scan. So in these babies, immediately after the baby is born, within first 7 days, we do this scoring called as new blood scoring. Based upon this scoring, here we can see that based upon the scores, we can assess roughly what is the gestational age of the baby, whether the baby is preterm, term, with preterm, how preterm the baby is there. So these are all the parameters that we have, and based upon the scores, we'll calculate the gestation age of the baby. So the next important thing is care of the cord. We have discussed that we need to cut the cord with a sterile blade. Once we have cut the cord, when we apply and we need to always use a sterile umbilical cord clamp. So once you cut the cord, we need to keep the cord sterile, keep it dry. There is no need to apply any powders, any ointments, any creams. If you keep it dry, don't get contaminated with anything, it will heal by itself. You always try to fold your diapers, nappies below the umbilicus in order to avoid the contamination with the urine and the motion. Suppose if the baby pass urine motion, if you fold this umbilicus, if you fold your diaper beyond the umbilicus, your umbilical cord get stained with the urine and the motion, and that can lead to the infection. Usually the umbilical cords fall by 7 to 10 days. When they get fall, they can have some light amount of blood and some light amount of yellow color, that is we can see when the cord has fallen off. It doesn't mean that some infection is there, and if you leave it, it will get shriveled and get completely resolved in a couple of days. If you unnecessarily put some antibiotic powder, clean it with water, soap and things, you will initiate more irritation, and that can lead to supra infections. We support exclusive breastfeeding. All the delivery units should have a breastfeeding counselor, and the doctor should be motivated, and we should try to always establish the breastfeeding before we discharge the baby from the hospital. And we advise the baby to lie down always in the supine position. If you keep the baby in the prone position, that is upside down, the baby sometimes we have seen that there is a syndrome, there is a disease called a sudden infant death syndrome. The baby might suddenly forget the breath and may die if you keep the baby ulta in the prone positions. And we should not apply any kajal. So we often see that mothers or the grandparents apply kajal, dark black color kajal to the eyes, and to the also to they apply something over the head. So that kajal, we don't know how they are made. Even they made that things in the home, but you are getting the products from the outside. They are getting adulterated. That can lead to the more infections and allergies in the babies. There is no need to put any oil in the ears. Putting oil in the ears will lead to infection. It will not useful. It will not be useful, and you are harming the baby. And don't apply any cow dung or any turmeric powder on the cord. So these things are no means no. There is no discussion in them. And also we should not give any honey to these babies. Previously, we used to listen when during our childhood, our relatives used to use some kind of honey. This is called the prelactal feeds for the babies before they start breastfeeding. That is an absolute that we should not give it. It can lead to a dreadful disease called as botulisms, and the intestines can get damaged because of giving the honey. So only the breastfeeding. If you're not able to successful the breastfeeding, then we need to give the formula feed. Other than that, we should not give any honey or some kind of medications, Ayurvedic medical like good water, grape water. They are not suitable for the babies born less than 6 months. Either milk or the prescribed medications from the doctor is need to be given. Other than that, we should not give anything. And usually the common parental concern is my baby is losing weight. My baby was born with 3.5 kg. Today my baby is after 2 days baby has lost maybe 200 300 grams. Why my baby is losing weight? I don't want my baby to lose weight. No, it's not. It's normal for the babies to lose weight initially once they've been born. because when the baby was getting delivered, they have more amount of water in them. They need to lose that extra water from them. So normally the term babies lose around 7 to 10% of the weight in the first week of life. And they usually start regaining from 3 to 4 days and usually reaches the birth weight by 10th day. And after that, they gain around 150 to 400, 200 grams per day, per week. That is around 20 to 40 grams per day. But the preterm babies have much more water in them, so they lose more water compared to the term babies. Even though they may born at 1.3, 1.2, they may lose compared to more weight because they have more water in them. So they can lose up to 15%. And they start gaining the birth weight. They reach the birth weight a bit late by 10 to 14 days. This is normal for the babies, and we should understand that. Small for gestational babies, these are the babies who are born very low compared to the same kind of gestational age. So these babies have less weight compared to the counterparts because they have certain medical issues in the mother that might have led to inappropriate growth for the baby. So also we've seen so often that especially in the first born babies and especially night times, they usually bring the babies over the night to our ER. So telling that my baby is crying excessively and we are not able to console my baby. So during the first few days of life, babies sleep more in the daytime and more awake in the night time. Sometimes they may just sleep maybe 1 to 2 hours in the night, but may sleep entire day. This is common. The diurnal pattern, that is the awake in the daytime and the sleep in the nighttime, will take at least 2 to 2.5 months of the babies to get to adjusted that routine day and night pattern. Whenever the baby cries, it means they may cry for multiple reasons. It always doesn't mean that they are hungry. So they can be hungry, they might be discomfort, they might want some skin contact with the parents, they might want you to hold them close to you, they might want some attention from you, or they might have passed some urine or motion, and soiling of the urine motion will be much irritation to them. They want to clean that, so they can feel some kind of cold. So all the things can lead the baby to cry. So whenever a baby is crying, so first we need to try to give the milk for the baby by giving the breastfeeding. If the baby is refusing and still crying, then we need to check whether the baby is feeling cold or if the baby has passed urine and motion. We need to clean it. If after that, after gently holding the baby close to this and gently rocking the baby, if still the baby is not able to console, then the time we need to bring the baby to the hospital. Majority of the times, we often see that by the time the baby reaches the hospital, baby stop crying and babies starts smiling or maybe active. So sometimes the intestinal movements will be painful. They're called as a colic. One of the intestine can just penetrate into the adjacent intestine, so they can have excessive cry. And by the time the baby they've decided and started to come to the hospital throughout over the journey, maybe because of the bumps or maybe because of the movement in the car, this intestines will get relaxed and this colic pain might get relieved. So we don't know why the baby is crying, but as a doctor, we can check the baby and can tell that, so your baby is crying and we don't have any danger signs, so we can reassure the baby, we can try to feed the baby, and after a certain point, if the baby is okay, then we can again send the baby home. Sometimes baby passes during the motion and cry during the passage of the motion and urine. This is normal for the baby. If they persistently crying during the motion every time, they persistently cry whenever they're passing the urine every time, then we need to rule out the urinary tract infection. These babies might not tell you that they're having a pain, so they just cry while passing the urine. But majority of the times it will be normal. But if you have a persistent symptom of crying during menstruation, then we do the basic test for the urine test to rule out the urinary tract infection. So when do you want to bath the baby? So normally, as per the guidelines, so we don't bath the baby in the hospital. Definitely, we usually advise to bath the baby after your umbilical cord get dried and fallen off. If you bath the baby before that, there is high chance of your umbilical cord get infected, and the chance for getting this umbilical cord infection is more. So usually maybe around 1 week we don't bath the baby. Till then we can just spawn the baby. We can take a clean cloth, lukewarm water, and we can just wipe the baby. Routine use of the wet wipes is also not useful because the wet wipes contain 99% of water, but 1% of chemical will be there. In a case of emergency, in a case where you're not available of having this kind of facilities, you can use the wet wipes. Other than if you're going into the home where you have the facilities, you always clean the baby with a clean cloth and a lukewarm water, just sponging the baby. And don't touch the umbilical cord. The umbilical cord to get dried and then only it get fall off. So we need to, whenever you start the bathing for the baby with the umbilical cord fallen off, we need to give a lukewarm water, not hot water, and the bathing should be quick. There is no need for rubbing the baby too much. It lead to the damage to the skin and your skin get rough. And the head should be washed last and it should be the dried first because newborns have a large head, and if you keep the head wet, they lose more amount of the temperature. Sometimes we often get the complaint from the parents that my baby is having vomiting every time they feed. So this is not vomiting. This is called as spitting. This is called as regurgitation. The milk can go from the stomach to the mouth because they take so much of liquid diet. The reflexes are not that great. The control is not that great. There can have some amount of regurgitation can happen. It can happen with every time. Sometimes they feel that third kind of the milk is coming out. That is normal. This is called as regurgitation. As long as your baby is gaining weight, passing urine around 6 to 8 times, small amount of the registration, there is no need to further treatment. We should worry if there is a large vomiting, the baby is not gaining weight, or if your vomiting is dark yellow or green colored, or if it is associated with a very tight abdomen or very distended abdomen, then it's the time to meet the doctor immediately. Then sometimes we parents show the diaper that, sir, my baby is passing some kind of a blood in the urine. See, you can see that. So they can see that small kind of crystals, small reddish kind of things will be there. So that is not blood. That is actually urate crystals. The urate crystals appear like a small pink to a bit mild red color of the crystals. So this is not because of bleeding. It's because of inadequate feeding lead to the concentrated urine. If you feed the baby properly, slowly that will get waned off. But if you find this, please show to the doctor rather than just assuming it a urate crystals. Next, diaper rash. See, the rashes are more common because of the inappropriate use of the diaper. If you are wearing the diaper for a long period of time, if the baby has passed stools, you are not cleaning, so that contact with the stools with the skin lead to the excoriation. So always try to change the diaper every 3 to 4 hourly and clean the stools as well as possible. Always try to keep the diaper area dry and avoid using excessive pressure in order to clean this thing. And as I said, here also there is no need to use a wet wipes every time. You can use with a soft cloth and a lukewarm water to clean the motion also. But whenever you're outside, like you come for a OPD visit or you're gone for any family visits or you've gone to some trips, there then you can use wet wipes. But as soon as possible, when you come back to the routine place, you try to clean with a lukewarm water, not with soap and water. Just a lukewarm clear water, not clean, clear water with a soft cloth. So the next is stool. So some patients, usually the newborn babies pass stool in the first 24 hours of life. That is mandatory. If they're not passing beyond 24 hours, we always try to evaluate why they're not passing. So after 24 hours, in the first 4 to 5 days, they usually pass meconium. The meconium is black to green color stools. That is normal for the baby. After 5 to 6 days, slowly they can pass soft, semi-solid, loose stools. And now that can pass for 2 to 3 days. That is called as the transition stools. After that, then they form a golden yellow, non-foul smelling, sticky, loose, semi-loose stools, just like a paste. So these are normal. So normal breastfed babies usually pass golden yellow, non-foul smelling, soft stools. Sometimes baby can pass stool as soon as we feed the baby. This is called because of gastrocolic reflex. Gastro is stomach, colic is intestine. Whenever the milk go into the stomach, automatically the intestine can move. That can lead to some amount of motion can pass from the baby. This is common for the baby and we should not worry as long as the baby is taking good amount of the breastfeeds, as long as baby is gaining weight, this is common for the baby. And there are certain skin lesions that you often seen, and we just have a look through this so that next time will be not that apprehensive when you find these things. So this is small. Sometimes you see the baby small white papules are seen over the face. So this is called as milia. It's because of retention of the keratin and the sebation. That is, oil kind of ducts will get blocked. That is lead to this kind of things, and they usually resolve within weeks. There is no need for any special treatment. Then this is called as malaria. Sometimes the babies will have some rash kind of things. So this is called as malaria. So the malaria is because of the obstruction of the sweat glands. So based upon level of obstruction, there are 3 different types: malaria crystalleria, malaria rubra, and malaria profunda. Usually we can see this kind of a eruption, kind of transient eruption, reddish kind of thing that you can see in the face to body. Usually they get resolved if your temperature is not that warm and you feed well the baby. But when you find this thing, you always need to show to the doctor because sometimes it can be viral infection also. But majority of the times it is because of malaria only, and they will heal without any support. Sometime on day 2, day 3, we can see this kind of pimples kind of things, reddish, or that there is small kind of a yellowish or a small papules will seen. So this is called as erythema toxicum neonatum is usually seen in the term babies on day 2, day 3, and usually get healed up within first 1 week. There is no need for any treatment. There is no need to apply any cream. This is normal for the babies to have this thing. This happens because their skin is getting adapted to the environment, or because of It may be some studies have shown that some maternal allergies also can lead to this kind of thing, but they usually get resolved without any treatment, and there is no need to have any dietary restriction in the mother. And sometimes we see that the one of the breast of the baby, either male or female babies, will have been swollen, and sometimes we can see small amount of the milk also getting dribbled from them. So this is called as breast enlargement. It is not any infection. It is because of the hormones from the mother to the baby is being transferred that lead to the transient swelling of the breast. Some in the rural areas, the grandmothers used to try to squeeze it and remove the milk. So we should not do all these things. It will get automatically subsided in a week time. If you squeeze it, remove that milk, it can lead to the infection and swelling. That is more dangerous rather than leaving it itself. So don't do anything. Whenever you find this kind of things, you can show your doctor. Majority of the 99.9%, there's nothing to be done. If you give some time, it automatically get healed up. There is no need to milking of this breast. And sometimes majority of the babies you can see whenever the baby is born, there kind of some dark spots that are present in the back, hands, and these things. This is called as a Mongolian spots. This is a congenital. It's also called as congenital dermal melanocytosis. It is very benign and usually get improved by 1 to 2 years. It get faded off. It's because it's not any disease. It's because of delayed disappearance of dermal melanocytes. Usually they are seen in the back of the buttocks. Sometimes they can be seen in the hands. So this nothing to worry. They usually get cleared by 1 to 2 years. Sometimes we see that sometimes the babies can have this kind of a reticular kind of things, network kind of things, especially when they've been exposed, when they're cranky, when they're extremely happy. So this is called as cutaneous marmorata, where you can see this symmetric reticular mottling of the skins. This is usually caused by vascular response of the body to the cold, and also usually it get resolved with warming. No treatment is required. It's not any disease. And this is, we can see here now, the hands of the babies are blue, the body of the baby is pink. So this is called as acrocyanosis. It is very common finding in the newborn babies, especially in the first 1 or 2 days. The hands and the soles usually appears, the hands and legs appears blue color, and whenever they are being warmed, they again turn to pink. So this is normal. It's because of the vasoconstriction. The blood vessels will constrict as soon as exposed to the cold. Usually more commonly seen in the premature babies, and they usually respond to the warming, and usually anyway it get response to the age. So sometimes we can see this kind of specialized stain where they can present as a pink red patches, maybe single or multiple. This is called as nevus simplex. This is called salmon patch or stroke bite or angel case. So it can be seen in the forehead and also in the you can see in the back. So usually 40 to 60%, most commonly we can see in the eyelids or in the forehead, in the glabellar region, or in the midline and the nape of the neck. So rarely they can be seen in the nose, lips, and the back. Usually this get fade off in 1 or 2 years, but sometimes they can persist also, but they usually doesn't cause any problem. So this is called as nevus simplex. So in this way, these are the common the problems. Usually the parents have the concerns, so we discuss these with them before we get discharged from them. So once we have trained them, they are confident, and we have a checklist before the discharge. Before discharge, usually the infant should be discharged after 48 hours when all the criteria are fulfilled. So we check the jaundice in the baby. The jaundice usually happens for every baby, but if it is very high, we give the phototherapy for the baby. The jaundice will progress from the face to down. The hands and the legs and the eyes get stained very late when the jaundice levels are much high. So we'll check the jaundice with a machine or with the blood. If the jaundice levels are low, we'll discharge them. We'll give the basic vaccination for the baby. We'll give the BCG vaccine on the left hand, left shoulder, and we'll give the hepatitis B and the polio drops. So when the immunization are done, we check whether the mother is able to give the breastfeed. We ideally try to establish the breastfeed before the discharge. We assess whether the baby is able to pass 6 to 8 times urine a day and sleep well after the baby is being breastfed. And mother should be free from any illness so that she can take care of the baby, and she should be confident enough to identify the problem that we have said earlier. And mother should be trained regarding the certain danger signs, and we advise them to return immediately. I'll enumerate the important danger signs, and we'll give the next follow-up. Usually we'll call the mothers after the 48 to 72 hours until unless the danger signs are there. And we start the babies on vitamin D, 400 additional daily, and then we give the 1 dose of the vitamin D, train the mother how to give the vitamin D, and then we discharge the baby. If all the checklists are met only, we'll discharge the baby. So these are all the danger signs. If the baby is not taking feed, the baby is appearing jaundice, the palms and soles are getting yellow, the baby is not passing of urine. Nowadays, within 24 hours, we are not discharging. Usually, we don't discharge before the baby passes urine motion. Or if the baby is extremely sleepy, not getting aroused, and if the baby getting excessively crying, not able to stop, is having any fast breathing, a baby is becoming blue, If there is any temperature difference in the baby, the baby should not feel, the temperature should not fall below 36.5. At the same time, should not cross beyond 37.5 degrees. If there should not be any bleeding from the nose, mouth, the umbilicus when getting separated, there can be slight staining of the blood present on the skin, but the profuse bleeding should not be there. The baby can have agitation but should not have a persistent vomiting, especially green color vomitings and dark color vomitings is very dangerous. There should not be very loose stools, small amount of semi-solid stools, a bit watery on the third and fourth day is normal as long as the baby is active. There should not be any drooling of saliva or choking during the feeding. There should not be any seizures, fits in the babies can happen sometimes because of low sugar, because of a low sodium levels, or because of brain development. So any seizures is there, we need to bring the baby immediately. And we also tell that any infections in the baby like eyes getting redness or any pustules, even though certain type of pustules and the certain type of rashes are normal, but they should be shown and get confirmed from the pediatrician that they are normal. Any redness and any pus discharge from the umbilicus, any kind of oral thrush where they can find some white kind of a patch over the throat or over the tongue or the buccal mucosa. So these are all the danger signs. Whenever these danger signs are there, they need to report us immediately. We'll give the list of all the danger signs and then we discharge. So with this, we routinely manage the newborn, and these are the common newborn problems that usually faced by the parents, which we address in our delivery units and in the OPDs.
Thank you so much, sir. It was very informative. We have few questions in the chat box. I'll be going one by one question. You can just answer those questions.
Yeah, please go.
We have a question from Kumar. Good afternoon, sir. How should parents approach bathing and cot care for newborn?
Yeah, I've already told. So as I told you, the bathing, as long as the baby is in hospital, we are not bathing the baby. We're just doing the sponging. We advise to bath the baby after the umbilical cord gets fallen off.
Yes.
And don't apply anything on the umbilical. You keep
We
it
have a
dry.
question from... Yes, sir.
Yeah, you always keep the umbilicus dry. And there's nothing to apply on the umbilicus, and wear the diaper below the umbilicus. That's it.
Okay, sir. We have a question from what vaccination are recommended in the first month of life?
So at the birth, we usually give the BCG vaccination, OPV, and hepatitis B. After 6 weeks, then we'll give the DPT, Hib, rotavirus vaccination, hepatitis B vaccination, and pneumococcal vaccination.
Yeah. And we have other question from Srihit. How can parents monitor the newborn's growth and development at home?
So the problem with monitoring the growth and development at home will be a bit difficult. Development they can monitor. So for the growth monitoring, usually the baby gain around 20 to 40 grams per day after the birth weight has been. Initially there will be a dip. After that there will be weight gain. So from there reach the birth weight, there will be 20 to 40 grams per day. So you need to have a equipment that can provide the weight of the baby. But as long as baby is feeding well, passing 6 to 8 times urine, and baby is active and sleeping well, the growth should be okay.
We have other question from Vikas. What are the do's and don'ts of newborn feeding in the first few weeks?
So the do's: try to give only exclusively breastfeeding, provide adequate feeding, don't bath the baby till the umbilicus fall, take care of the umbilicus, don't apply any kajal, and don't put any oils, and don't give any food other than the milk. Breastfeeding is the best. If not, we can give formula feed. Those are the do's. Don'ts, again, there's a mixture of do's and don'ts, I told you.
Okay, sir. We have a question from Pawan. Why is skin to skin contact immediately after birth so important?
Yeah, the studies have shown that by providing the skin to skin contact of 1 hour, the chances of baby becoming low temperature, hypothermic is less. The chances of establishing the breastfeeding is more. The chance of babies getting low sugar, hypoglycemia is less. So that is the need for why skin to skin contact immediately after birth is important.
We have a question from Srija. How do we differentiate between normal newborn behavior and signs of concern?
So as we discussed, if you have any danger signs, as I enumerated, so these are the signs of concern. Just crying the baby, and sometimes the baby can also have sneezes. Well, sneezes also happen because the baby is not used to this kind of the perfumes, this kind of the smells that is coming from your cooking or coming from the floor cleaners, or even from the kind of the soap that you are using. So these all things can lead to some amount of sneezing. Other than that, if the babies are having any danger sign that we have enumerated before, this is a matter of concern.
Okay, sir. We have a question from Akash. Hi, doctor. What are the most important aspects of newborn care in the first 24 hours after the birth?
Yeah, we need to establish the breastfeeding as early as possible, preventing the infection in the baby, and monitoring whether the baby has passed urine and motion, taking care of the umbilicus, getting the birth vaccination as early as possible. So these are all the most important aspects of newborn care.
We have a question from Satvika. Hello, doctor. What role do family members play in supporting newborn care?
The support from the family member is a paramount importance. The newly delivered mother might not be in a place to take care of the baby all of a sudden. So the family should understand her things, should support them, should not confuse her with so much of myths, should follow the advice of the doctor. They can discuss with the doctor and clear their myths. And they should always, one person should be there to help the mother in carrying out the breastfeeding and motivate the mother for breastfeeding rather than promoting her for the formula feeding.
Hello, doctor. What common newborn health issues should parents be prepared for, like colic, jaundice, or rashes, or anything else?
So your breastfeeding, a proper breastfeeding will usually prevent the colic, all kind of thing. But if you have a colic, majority of the colic will resolve by its own. If it is not resolving, then we need to examine the baby and we can give specific medications. For jaundice, as I told you, if the baby's palms and soles are getting yellow and the eyes are getting yellow, it's immediately you need to take to the doctor. For prevention of jaundice, there is only one option. You can feed the baby frequently so that the baby jaundice will come down. The rashes, so the majority of the time the rashes appears and go away. So as long as possible, you are maintaining a good temperature for the baby, not having any allergic kind of things for the baby. The small kind of rashes will heal by itself.
Okay, sir. And we have a question from RV. How can new parents manage sleep schedule for the baby and themselves? Maybe this is important for most of the parents.
It's very difficult. So
Yeah.
rather than being a neonatologist and pediatrician, rather than being a father, I know how difficult it will be, but we still can't say anything. See, the baby's timing we can't adjust, so we need to adjust to the baby timing. That's why we need so much of support from the family members for helping the mother. So once
Yes.
the feeding is done, we can give the mother rest, and meantime we can take some other person can take care of the baby, or we can take turns. And suppose if you are nowadays we're having nuclear families, only mother and father will be there, so then it's very difficult for them to manage the baby, but they need to take turns and try to manage the baby. We can't set any schedule for the baby. Baby will put the schedule for us.
And we have one last question, sir, one from Kavya. What are some myths around newborn care that you would like to bust?
So we have seen so many things. So many things are already discussed. So we often see that in the first day, rather than mother, the grandparents are much worried. My daughter is not getting milk, so kindly provide the formula feed. She can't provide the milk. She can't do the breastfeeding. So every mother in the first 48 hours will get small amount of milk. That is a colostrum that is very important for the baby's immunity. So we need to counsel them, mother rather than mother, grandmother, in order to provide a positive impact on the baby, not to confuse their mother. Second, putting some, what do you call, honey in the mouth of the baby, sugar in the mouth of the baby is not at all good for the baby. Third, when mother take good amount of diet, including everything, either is a vegetarian or non-vegetarian, then only she will produce good amount of milk. If you provide dietary restriction to her, allowing her only to eat some mirchi kind of thing, some few vegetables, her diet will not be sufficient and she will not provide the proper milk. And don't squeeze the hypertrophied breast and don't remove any milk from that. That is also absolute. Don't apply anything on the umbilicus. So at least these things are the mandatory. If you maintain at least this, you can prevent so many complications in the baby.
Yes, sir. So that's all we have in Q&A, sir. So before I close the session, I just wanted to show the MedWorld platform, which made this session happen. So I'll just take 2 minutes and we'll close the session, sir.
Yeah, please.
So
I'll
thank
stop
you so
sharing.
much, sir.
I'll stop sharing.
I have already stopped it, sir. Yeah. I think everybody can see my screen. Can you
Yeah.
see my screen, sir? Yeah. First of all, thank you so much, sir, and thank you, audience, for joining this session. So this session has been conducted by MedWorld Expo. So I would like to showcase you what exactly the MedWorld Expo is. MedWorld Expo is a global healthcare platform where we will help all the medical equipment manufacturers and distributors to connect in our platform. So we also have another thing where all the healthcare medical organizations and professionals can do a lot of things in this platform. As we're in this webinar, most of the people are doctors and medical students and practicing doctors and other healthcare professionals. So I would like to showcase you what would be the major benefits that you will be getting from MedWorld Expo. So as you can see the screen, this is MedWorld Expo platform. How does it look when you open? And we have an option called network. And if you go to the healthcare service providers, you will be able to see in this way hospitals, doctors, laboratories, clinics, and biological companies. So you will be able to access different kind of companies with their point of contacts, where you can directly talk to them if you have any kind of requirements, or if you wanted to talk to if you wanted to make your network also. And we have an option called webinar, which you are already in the platform, and we will be hosting different kind of webinars every week, around 3 to 4 webinars on different specialities. So please join other webinars also in upcoming webinar sessions. If you can open the webinars, we have upcoming webinars also. Please, you can register to these webinars and you can attend. And we'll be starting this CME program soon. So this is credit-based programs. So like most of the doctors need these kind of credits to renew their license and different kind of aspects. So this would be one of the major thing that most of the doctors would always look for it. And we have knowledge option, where all the healthcare news and insights will be updated time to time. So as you are in hospital industry, you have to be updated with latest trends and everything, right? So we will be able to help you out to find the latest news, what latest things which are updated in the world. We have MedWorld blogs. As a doctor, as a student, as a practicing doctor, as a nurse, anybody can write any blogs in the over here. And sir, Vamshi sir, I would like to request you, if you are free anytime in today, you can also write any blog over here. Like frequently, most of the people who search for any topic. So, but that kind of topics you can just open and you can directly write a blog over here. So people can directly see it, and that would be most helpful for people. And we have medical communities. You can create your community, or you can join any kind of medical communities in our platform. Either it can be cardiology, dental, or any kind of gynecology. It can be anything. You can join the communities and make your network better. Since you're in hospital industry, you need to make connections, right? So MedWorld is the right choice for you to make your network, connect with different kind of doctors globally, connect with different kind of medical students, connect with different kind of people, healthcare professionals in the platform. And we have journals. You can browse all kind of healthcare journals in our platform. We have global med magazines. All the medical magazines were available over here. You can directly browse it. And we have career advancement. Most of the people who are graduated or post-graduated are looking to pursue studies in abroad, right? So our platform will help you to start, guide you from where to start and which location you need to choose, which kind of specialty do you need to take, how do you need to go, like what is the opportunities that you have in the future. So everything we will be assisting you through career advancement program. And we have option called job platform. This would be one of the major advantage for all the people who are into the healthcare network. So if you open either kind of job portals, it is complete for all the sectors, right? But in MedWorld Expo, it is completely specialized for only for healthcare. So you will be able to browse only healthcare companies where the available positions are open. If you can see, we have a lot of positions open at present. So you can directly register to MedWorld Expo and join and directly apply, so that medical and healthcare companies will easily understand that and easily able to take your application forward, and you'll be able to get a job easily. So use MedWorld Expo job platform for your networking or for your good job placement. So that's all about MedWorld Expo. And if you have any queries, you can directly reach out to www.medworldexpo.com. You will have everything over there. And thank you so much, everybody, for joining today's session. And thank you so much, Vamshi sir, for giving the valuable insights and one of the best PPT today presented by you. And I hope we will be doing much more sessions with you soon. Do you have anything before we close the session, sir?
Yeah, thank you for all the MedWorld team and all the participants for patiently listening this. So yeah, as
Thank
you
you,
said,
sir.
we'll try to associate for more webinars in the future.
Sure, sir. Thank you, sir.
Thank you.
Thank you all. Have a good day. Bye.